And good morning and welcome to my YouTube channel, Pain Free Partha. And most of my slides are also downloadable free from www.painfreepartha.com. And today's topic is about genomics and anesthesia. And it is not that simple topic, but it is an interesting topic. I will try to make it as interesting as possible. So, greetings from the Institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry Balaji Vidyapeeth University, Pondicherry, India. So, I don't know why I took this topic. Like, maybe I am an anesthetist. My second daughter is MBBS, and they both are involved in biotech. Probably this may be the reason. Like, now we will go to very basics. What is a genome? A genome is a entire set of DNA instructions found in a cell. It's an entire set of DNA instructions. That is what is called a genome. Full set of genetic information that an organism carries. Now it consists of 23 pairs of chromosomes located in the cell's nucleus and a small chromosome in the mitochondria. So it is all the information that is needed for an individual. He has to develop and function. For that, a genome contains all the instructions. That is what is called a genome. What is genomics? Genomics is a field of biology, studying of all the genomes. That is its genome. Now you see, this is the gene. This is the intergenic region. Now you have a chromosomes. Then there are so many pairs of chromosomes, and this is what is called genome. And the study of a genome is basically genomics. Somebody will be confused. What is genetics and what is genomics? Genetics is the study of heredity. It is a specific structure of a DNA of a single chromosome. One chromosome, one DNA. What is the sequence? Has it changed? That is what is genetics. Now, genomics is all the 23 pairs of chromosomes, how their DNA is there. That is genetic material completely. The study is called genomics. Now we have Huntington's chorea, cystic fibrosis, simple genetic diseases. But what happens in heart attack? Why certain patients are prone for heart attack? This study comes in genomics. Now, if you want to put it very simple, if you read in a book one sentence, that is gene. If you read one chapter, it is chromosome. If you read the whole book, that is genome. This is what is the simplest way of telling what is genome, what is chromosome, and what is gene. Now, what is pharmacogenomics? We know what is genomics. Now, what is pharmacogenomics? It's a branch of pharmacology that uses genomic information to understand individualized differences in drugs as a way to study the relationship. What is that? Now, I will tell you in simple things. It's a branch of pharmacology. It utilizes genomic information. What it does, okay, this drug is going to be acting in this way in this patient, where this genomics is like this. So it's a study of relationship of genome with drug response. It may be sensitivity, it may be pharmacokinetics, or it may be adverse effects. Now, for example, we are giving midazolam IV. For example, the patient is having a minimal plasma concentration of 108.4 nanograms per ml. The same standard drug dose may result in drug concentration from 1000 to 10,000. What do you mean by that? 0.05 milligram per kg of same intravenous dose, it can be either 108 or 1008 nanograms. That is what is called pharmacogenomics. Now, why should there be a difference? Okay, now we say one fellow has got 108, one fellow has got 1008. Why should there be a difference? Accordingly, pharmacogenesis, this is what the genetic variations contribute. The genomic sequencing, the genomic variations, that makes the difference. So, we study the whole thing of genomics and tailored to one patient for improved efficacy and safety. Okay. Now you study the genomics, you make it personalized and give the drug so that it is efficacious and it is safe. Now we have 3 patients on today's list. Number 1 is Palani posted for some hernia surgery. In propofol, he needs 0.8 and 1.1 milligram per kg of vecuronium. We have done genomic studies. There's one portion, Devayani. He needs 2.5 milligram per kg and only 0.08 milligram of vecuronium. Singaram, propofol may need 1.5 and vecuronium. This is what is the difference in patient's response to a drug that is implied by these genomic studies. Now we have cytochrome P450 that we know, everyone knows it is responsible for almost 80% of the first phase metabolism of currently used drugs. Whatever drug, cytochrome P50 goes, metabolizes. It is in the end. Now it has 3 families, P1, P2 and P3, which has got so many subdivisions. Now we see these are the metabolizing enzymes. We know local anesthetics, CYP3A4, benzodiazepines, CYP3A4, CYP2E1, narcotics and inhalational agents. Metabolizing enzymes. Now we have opioid analgesics, tramadol, CYP2D15, propofol, CYP, aspirin, different, neuromuscular blockers, CYP3A4. So these are all the metabolizing enzymes where the gene is involved. Now I am telling you, this is our article. The genotype of a non-functional allele, I will tell what is allele delta. If a non-functional allele is there, then there is a difference in tramadol in acute osteoarthritic pain. This is our article. Now we have told what is pharmacokinetics. We have told metabolizers, slow metabolizers, moderate metabolizers, rapid metabolizers. Now we are giving metazolam. You are giving to a patient with a slow metabolizer. Then what will happen? He will metabolize it slowly. But now you are giving a metazolam to a rapid metabolizer. He will metabolize it fast. So what is the genomics? Whether he is a slow metabolizer, moderate metabolizer, or a rapid metabolizer in pharmacokinetics of either metazolam or opioid, tramadol, whatever it is. I have already told what is an allele. This is that allele. Now you see, this is a gene for eye color. Now this is an allele for blue. This is an allele for brown. Now, this is the genotype. Now, what is the phenotype? Phenotype means what? Actually, the person is what color? Eyes, brown or blue. It depends upon which is the dominant allele. Okay. Now, the blue is dominant, you'll have blue color. That is what. Now, here if you see, allele for rapid metabolizer. This is blue, this is brown. Okay. If this allele is different, then which is dominant is determined. Again, this is also blue. Both are rapid. Definitely will be a rapid metabolizer. That is what is called allele and homologous chromosomes. Now we have warfarin. We use it routinely. We have CPVCR1 genes are implicated in warfarin metabolism. I am again telling these are all metabolism. Now, these genes are strongly and consistently associated with bleeding while taking warfarin. Now, if this gene is there, I should give 1 milligram. If this gene is not there, should I give 3 milligrams? So, because this gene is associated with more bleeding. Again, if you see CYP2C19 star 2 and CYP2C19 and 3, if this loss of enzyme activity, then there will be a 25% to 50% dose reduction of benzodiazepines. Now is the influence of metazolam. This is an article long back only, 2019. Genetic polymorphism relating to metazolam, which has upset the sedation during UGI-scopy of a Korean population. Regarding ketamine, CYP3A is involved, whether there is a clinical evidence is not proved yet. But propofol, you see, it is metabolized by 70% by this family, this gene, and 29% is by this gene and this family. If there is any problem, now if you see the propofol metabolism is changed. Now what we have told is pharmacokinetic. They are all metabolizers. Okay, first pass metabolism, cytochrome P50. Now we will go to pharmacodynamic. Okay, no problem in pharmacokinetics. We are giving the same concentration of this thing is there, but there are differences in pharmacodynamics. If the patient has got a beta arrestin 2 gene variant, they will have a poor tolerance to morphine and they may need opioid switch. If there is an MCA1R gene, then there may be a dose requirement of desflurane may change. So these are all pharmacodynamics and gene variants. If there is a presence of beta-arrestin 2 or MC1R, the change is there in the pharmacodynamics of morphine and desflurane. Now, pharmacogenomic variability and adverse responses to anesthetics. What we have told now, pharmacokinetics. What then pharmacodynamics? These are all related to effects. Now I am going to side effects. Malignant hyperthermia, nitrous oxide toxicity, perioperative adverse events. It's very difficult to put it as a gene because there are a lot of variations, environmental changes, surgical trauma, hemodynamic challenges, so many things are there. But also you see multiple susceptibility genes. Now if you have an hemodynamic problem, then these are all the problems, and then also a multiple susceptibility gene is there. If you want to dissect the genetic factors affecting phenylephrine infusion rates during anesthesia, now you see, if you see genetic factors, phenylephrine infusion will change. If the gene is changed, there is also, if they can DNA genetic diseases, DNA sequencing, yes, we can find out and reduce infant deaths. Now I have one more. Now, if you have given spinal and the BP is stable like this, it's rare, no? Now, what we have done is, we have done this compound Isadis indicotica and we have done the complete chloroplast genome sequence here and changed this so that the hemodynamic imbalance following spinal anesthesia is decreased. The susceptibility by the way of gene is decreased. I'm not telling all the patients will go like this. The susceptibility by the gene is decreased. If you do this sequencing and do a change, then you are likely to get BP less fall after spinal anesthesia. Now we know controlled trauma. It's a controlled trauma. It's not like accident. Operation is a controlled trauma. Now operating room environment, a surgical injury, exposure to bypass, there is anesthesia, drugs, host response. What is the adverse event? The adverse event may be a cognitive dysfunction. The adverse events may be a myocardial injury. The adverse events may be a bleeding problem. So this is the normal outcome. That's what I told, phenotype. So all these things are there. But if you see, this genotype can also influence the host response to injury. Now we have always told old age is a risk. Malnumbity before is a risk. Goldman's cardiac risk index is there. But are we going towards genomics? Stroke genomics. Now if the patient has got this genomic sequence, is more prone for a stroke, is more prone for a perioperative stroke. Who will develop postoperative thrombosis? Now you see, organ-specific perioperative adverse reactions, infarction, renal compromise, thrombosis, transplant rejection, death, where candidate gene association studies, specific genotypes are associated with these problems. Now you see, during transcription, the enzyme RMA polymerase, this is green, uses DNA as a template. This is the template. Yes, produces pre-mRNA. Then it produces mRNA. It comes out from the template of the DNA, mRNA, and then this mRNA into the ribosome gives out polypeptides. This is the basic. If you are going to change here somewhere, the problem will change. Okay, that is what is called the biomarker. Okay, now you have the injury has caused something, kidney injury, and there is a problem here. The template is producing mRNA. This mRNA is producing polypeptides. That is why we are going for what so-called NT-proBNP in ischemic disease or perioperative injuries. So biomarkers. This polypeptide is produced by the mRNA by a template from DNA because of some problem. Now we have adverse perioperative cardiovascular events. Okay. Now you see this gene is IL-6. If there is a polymorphism, polymorphism is some variant. If this polymorphism is there, if you do a thoracic surgery, your adverse perioperative events are 1.8 times more. For example, this gene, this polymorphism, major vascular surgery, your adverse perioperative complications are more by 2.4 times. Your this gene, this polymorphism, thoracic surgeries, your events, bad events are 2.5 times the odds ratio is more. Now, what is genomic sequencing? Cut the DNA into overlapping fragments and sort it and clone the fragments like this. Sequence each fragment, we know what is what, and then order the sequence with a computer software. This is what is genomic sequencing to understand the genome. What is multi-omic molecular profiling for precision anesthesia? This is 2023. Now you see precision anesthesia needs multi-omic. What is multi-omic? Omic means simple. Genomic, proteomic, transcriptomic, all these things. If you use multi-omic molecular profiling and network biology, we can give precision anesthesiology. So operation does so many things. Perioperative stimulus surges, drugs are known to alter elements of the molecular profile of the RNA and protein expressions. These molecular changes are associated with postoperative complications. It's not that only simply your bleeding is there. The stimulus, the stress, the drugs, the trauma also changes the molecular profile such as RNA and protein expression of the RNA. Now there is something called ASO. We know ASO, that ASO 99. This is antisense oligonucleotide. Now we have CMV retinitis, cytomegalovirus retinitis. Now this retinitis, we are not going to kill the virus. This retinitis is causing inflammation and problem. Now you use this formivirsan. What happens is it causes a change in the genomic sequencing so that the retinitis is decreased. Okay, that is what is called antisense oligonucleotide. There are a lot of things, these have come out from the trials. There are a lot of things on the trials so that this, it is not going to affect the virus, but the virus is causing some problem. The virus is causing a retinitis. There we are doing something so that this oligonucleotide stops the inflammation by way of changing the genome. Genomics are also drivers of postoperative outcomes. For example, now your preoperative immune profile and it responds to surgical threats predicts surgical site infection. You see, there are three things in a hip. Number one is pain. Number two is functional recovery. And number three is infection. All the three can be predictedly preoperatively by an immune profile. Now we have an interesting slide here. Now this is a cesarean section. Now, if you see, if you do the genomics, we know how much the patient is going to bleed in a normal case. Okay, this fellow is not prone for bleeding. The DNA trait association is not for bleeding. Now you see, you operate on a laboratory. How far the lung function will decrease? Okay, leave out this operation, trauma, lung morbidity, pain, all these things. How far they are more? Yes, they can be straight by these traits. Actionable molecular related to commonly SCC, 91.2 are variants. That means how much we can predict. 91.2% are unpredictable. Only 9.8% we can do. Metazolam will do this. Propofol will do this. Clinical implications highlight the importance of next generation sequencing data into pharmacogenic approaches and personalized medicine. Now you come, you do a sequencing next generation. You take a pharmacogenomic approach to a personalized medicine in administration of drugs. 9p21 chromosome has been strongly associated with infarction. Now what we know to do this genomic sequencing, you just need to send a buccal mucosa, even a drop of blood or some saliva is enough to do a genomic sequencing. Now it was costing so much, now it is costing less than $1,000. Now there is a poem by the Bharatiyar. He said, Akkani kunjondru kandeen and the younger kattil pundirin vaiteen vindu tanindadu kaade. Ignite. So what is ignite? Implementing genomics in practice. That is what is ignite. Now, previously what we do in 20 years ago, we don't do echo at all. We just don't do even ECG of many patients, 20-25 years back. Hemoglobin, blood urea, sugar, and in some cases we do blood grouping. But now what is it? We do prosthrombic time, we do ECG, and more than 65 years we do echo. We have to change. Sometimes from now, yes, we can happen. Do a genomic sequencing before surgery. What is genomics? I have already told. Textbook, chapter, and sentence. Complete chromosomal genetic studies. Sequencing can be done like this. Anesthesia drugs like midazolam, morphine, fentanyl, local anesthetics, inhalational agents, every drug has got variations in relation to genomics. Preoperatively, by studies, we can predict that this fellow is going to bleed more. This fellow is going to bleed more. This fellow is going to have postoperative lung function more. This fellow is going to have perioperative cardiovascular problems by 2.8 times odds ratio. Intraoperatively, yes, we know if we give the drug, yes, 108 and 1008. Postoperatively, complications are less if we do sequencing. And so, can we do sequencing? Everyone before surgery? Yes, the time to tell. Thank you all and welcome. Thank you all. Welcome to my YouTube channel, Pain Free Partha.